Right. So you guys should see a CT scan.
Good.
So my colleague Daniela shared this case with me. This is kind of cool, and this is a good case for trainees as well, just because this is something I know that comes up a lot on board exams. I think this was some kind of cancer follow-up, but a nice example of elastofibroma dorsi, or plural in this case here, in the usual location, sort of just below the scapula, deep to the serratus anterior. But what's kind of cool is there's a PET CT, and these can be metabolically active. But you'll notice already on this PET scan, let me make it a little bigger here, we're seeing a lot of activity in the subscapularis muscle, and that can just be from metabolic, just motion on the table. But there's also sort of these higher ones up here in the neck that seem a little bit unusual. We'll go back to the original CT, and then of course we have uptake in there. So, and there's the cancer, probably a lung cancer or something. But anyway, so these can be metabolically active, and it's one of the pitfalls is don't think these are disease. But what's cool is if you look on the back on the CT, there's this extra soft tissue here, just deep to, oh, I even forget the name of this muscle here coming down. But it's deep here, and there's one on the other side too. So just a smaller one. But so these are like 4 elastofibroma. There's one up high, and then there's a separate one down in the usual location. Have you guys ever seen elastofibromas elsewhere other than just below the scapula?
No, just there. I don't
Yeah.
think I've seen higher up or one like that higher. No.
Yeah.
That I've noticed at least.
Yeah. Yeah. I mean, pretty classic. They're more common in females and seem to be more common on the right. And whether it's some kind of use, a friction type process, unclear. But I just remember it's important to recognize these so you don't biopsy them. They can be FDG avid. And this is just I've never seen them up here.
Oh, that's really cute.
You can see them. And so that was that. This is just a classic case, but something we don't always see. So another good case for trainees, or a good sort of boards case. But we see diffuse small nodules, very discrete, and they're all upper zone predominant. You see sort of a gradient there, and I'll mag them up a little bit, and you can see just how round they are. And so this is pretty classic for a pneumoconiosis, either silica or coal. This was actually a coal miner who had spent 25 plus years in the mine. And you can see there's some hilar lymph node enlargement. And these are sort of along the spectrum of the ILO classification of around the Q. There's a few R's, so they're sort of 1.5 to 3 millimeters, and then a few that are a little bit bigger. And there's maybe a large opacity forming right here, some coalescence at least. And this is always a challenge. And on the B reading of these is it a large opacity or not? So you kind of look for the margins, but you kind of get the sense there's coalescence here. But this is just a nice example of pneumoconiosis, a co-worker's pneumoconiosis. And I don't have a CT, and we normally wouldn't get one on these anyway. And there's some paratracheal stripe thickening too. So pretty classic case. This is something I've never seen before. I came across this and I pulled an older CT that had better images. And it was on a PE study that I saw, but there's this fatty mass here just posterior to the left atrium that looks like it's within the pericardium, and you can see a little capsule around it there, and it pushing a little bit on the coronary sinus. But big lipoma. Have you ever seen a lipoma in the pericardium? I'm guessing it may be just deep to it in the epicardial fat.
Oh, no, I don't think so. No, I've never seen a lipomatous lesion benign quite there. I've seen a big tumor that involves the lower mediastinum that's fatty, but
yeah,
that I don't think so.
Yeah,
Jeff, I think I showed one lipoma in that region, but mine wasn't. I don't think mine was. I think mine was just posterior mediastinal.
right.
It was a few, maybe a month or two ago.
See, I think it's.
I wasn't sure if it was associated with the esophagus or if it was just. I think I just ended up calling it posterior mediastinal.
Yeah, I think this one is intrapericardial, just given
yeah
tissue around it there, and then this plane here, and then how it's just right up against the left atrium and everything, and even kind of sneaks up there a little bit. So yeah, that was just kind of a little incidental finding. It'd been there for years. I pulled the CT from a few years ago just because it didn't have a lot of artifact and looked kind of easier to see. And then this is a trauma case here, and this just illustrates how hard these portable radiographs are. So this guy fell from some construction scaffolding, and you can see there's a lot of stuff over here. Lungs look pretty good. We don't see anything wrong with the mediastinum, and there's some artifact over there, but you don't see anything initially, and it's hard to tell what exactly is over there. It almost looks like that's somebody's hand. That's actually his own hand there, or somebody's hand. So yeah, nothing on. So of course, with an injury like that, you're going to get a CT scan, appropriate trauma management. And what's kind of cool is one of my residents showed me this, is there's a posterior dislocation of the right humeral head. And these can be really hard to see on a radiograph, so we'll go back to it. But there's a little fleck of bone there. So there's a Hill-Sachs deformity here, and then you've got a reversed Bankart lesion. Let's do it right. Little injury probably right there's a little fracture there. But yeah, these are tough, and they're tough even on a dedicated show.
Yeah, Jeff, I think the position of his arm and his hand too has to be a clue that there's something going on, because that's a really weird position unless he's had a stroke and has a contracted extremity.
Exactly. Yeah. But looking at this, it sort of more looks internally rotated, the ice cream cone. But yeah, I mean, again, on these trauma radiographs, we're looking for big pneumos, big bleeds. Try to pick up some rib fractures, clavicle fractures. The anterior dislocations I find are pretty simple. Yeah, there we go. Thanks. Yeah, but this is tough, and you can see there's a humeral fracture too, so it's not.
Yeah.
So anyway, all right. Well, that's what I have. I have a few more later if need be. All right, let's stop sharing. Okay, who would like to go next?
I'm available anytime.
All right, I'll give you screen.
So the first case I want to show you concerns the presence of opacities in a patient who has received stereotactic ablative radiation therapy for 2 lesions. And the reports on the CT scans describe increasing opacities compared to the comparisons. And of course, just the description, otherwise unqualified, of something increasing over time concerned the radiation oncologist. So she asked if I could look at it. And as I'll show you in a moment, she also provided an image of the isodose curves, which we don't ordinarily get, but you'll see it is actually quite helpful. So let me go back in time and show you the appearance of the lesions and the change over time. So this is, I'm just trying to get the date to come up, and I think I pressed the wrong button. So this is January of 2021. Sorry about that. Don't know that came up. Let me go back to here, and I will show you that here is one lesion. This is a lesion that was biopsied and did yield a cancer. But the second lesion, because of the patient's clinical state, it was decided to forego histologic confirmation of the second lesion because of the judgments about the potential harms of doing a biopsy and the benefits. But this lesion was radiated as well. So we have those 2 lesions. So that's then. Now let me go forward in time. Make sure I have the right timing of things. So the images, let me just make sure I've got the right timing of things. Yeah, may have mixed things up here. Now this is the initial one right here. Something wrong with the dates, just give me a moment. Okay, so that's small lesion and getting a bit bigger. Let me just go forward in time. Okay, that was the PET scan that showed the biopsy. Excuse me for this. Because the radiation therapy was in December. So here we have an image from July, and you can see there's more opacity there. And in relation to the other one, we see more opacity. Now, you can see that this one involves a big area of lung, and it's just ill-defined. Here's a more solid opacity, but it's also surrounded by some additional ground glass. Let me go to the most recent, which is this one from January. And we can now see that there was definitely more opacity at both locations from before, but now it seems to be organizing a bit more in the sense that the lesions seem to be, certainly this one, shrinking a little bit, occupying less volume. And then this one certainly changes its morphology. So now it almost looks like two contiguous lesions, but you can see the morphology of it. But suffice it to say, this was described as a little bit increasing over time. So I looked at all of those and then also had, and now I'll bring up the curves over here that she sent me. So with respect to the one down here, you can see that even though there's more ill-defined opacity, it's still very readily encompassed within at least this isodose curve here in blue, which is up around 35 gray. And with respect to this one up here, you can see that the entirety of what we have now is still easily encompassed within certainly the blue isodose curve, which is here, well, there's a dark blue, like 52 gray. So that actually is very reassuring. So first off, you can get an increase in the size of the opacities in the first year. And this is the kind of article that also looks at trying to correlate the location of the opacity that you have, and if you have isodose curves. And to summarize this article, they say, for example, if all the opacity that you have is still encompassed within the isodose curve that represents 20 gray, that's reassuring, right? So sorry about that. And that's basically the thrust of this article right there. But they do make the point that sometimes you can get an increase up to 1 year, and sometimes even a little bit more than 1 year. But if you have that information, and you also have the isodose curves, that's really helpful in reassuring one that it's not recurrent tumor. So typically they will continue to image these at about 6-month intervals, and that's what they're going to do. But I found it very helpful to have the isodose curves to confirm that all of the opacity that I was able to see, including the most recent one, was still encompassed within that isodose curve area. And in this case, it was easily encompassed within even the 52 gray, not even the 25, but which is this light blue, but easily encompassed within that higher dose range right there, which is, these are centigrade, so 5,250, 52 gray. Have you guys ever had to do that before or potentially found it useful in cases that might be a little bit perplexing or
Well,
solving?
I was going to ask, has anyone, clearly you were successful in getting the isodose curves in this particular case, but we've been trying for years to try to find a way to get them more routinely, whether they're on packs or somewhere where we have access to them. Has anyone been successful in doing this?
I haven't, and these images
No.
I'm showing you, people sent me by email. She just took 2 templates, so it's not like the whole thing was sent to me, just 2 images that she personally took pictures of and sent it to me.
You would think, because I mean, I've been down to radiation oncology before and seen their really fancy software. It's kind of really cool, but you would think it would have an interface to push it as a DICOM object.
Yeah, I would like to get it kind of routinely, or if not routinely, be able to easily get it.
Yeah, or put it in the
Quite
electronic medical record
make a
somewhere.
comparison like this, which is really nice to have.
Well, if anyone figures out how to do it routinely, please let me know.
Yeah. So that was really nice to have that and put it all together. Okay, let me show you. Some of these are from last week. I don't know if is David on at the moment. Does he like this case? This is a really unfortunate patient with metastatic melanoma and growing tumors, and really so severe that for palliation they decided to resect these. So there was a big operation, and they did that, and they also actually took off the upper extremity that was involved. And we have post-op radiography, which is this one. And this one here is, let me just go back here, because this observation I made here, this wasn't obtained for this observation. It was obtained, I think, to maybe, because it was a long operation, they're looking for retained objects, kind of the up film. But I noticed that the diaphragm was up, and thought of the possibility that as part of the operation, they had done an intrascalene block, and that this reflects anesthesia of the phrenic nerve. And that turned out to be the case. So a couple of days later, the diaphragm is back where it should be. And I was able to confirm by going to the medical record that sometimes they actually leave a catheter in place if they want the anesthesia to last a bit longer. So this was a catheter-based intrascalene block. And as you can see, the diaphragm that was up came back a couple of days later. I don't know for sure whether this actually made him symptomatic in any way, but it's just a nice case in putting it together with the clinical context. Anesthesia of phrenic nerve.
Very cool.
Yeah. All right, David, do you like? You've shown that before. We've shown that before, right? But I knew you would like that.
Howard, what did you say the block was being done for?
I think it was part of the anesthesia. Had a big operation that operated on the chest.
Okay, for the axillary.
And also took his arm off because it's really unfortunate. So I think they left it there for pain control.
Yeah, so absence of the humerus is present on those images that you showed.
Yeah, there's tumors there. It's all pretty bad. I don't know if it's infected or not, but this was progressive melanoma tumor in that area. Really unfortunate case. Well, this one was kind of instructive. So this is scary. So give you a moment to look at that. This is a 29-year-old person, and it said chest tightness. And reading it at the end of the day, I did notice and actually remarked upon the fact that the hilar appear enlarged. But of course, everything else looks okay. And with that history and the kind of histories we get, I didn't make much of it. Now, in retrospective, they had told me that she actually, the real reason she came in was because of a substantial syncopal episode, that she fell down, and it was real. And the roommate found her down, brought her to hospital, and she was hypertensive. Then one approaches this thing differently. And yes, the CT was done quite soon thereafter, and this is always really scary. So yes, but it's not lymph node enlargement, it's really big PEs. I don't know why a 29-year-old gets such big PEs, but that's what they turned out to be. So there's a differential for that, but I was a little bit annoyed that I didn't get the proper history. I thought it was probably just lymph node enlargement. So kind of scary, but there you are. In looking for mosaic, or rather regional oligemia, or vessels that are clearly in the periphery of the lung, very narrowed, that is like a Westermarck sign. I don't perceive this. This obviously is just a slab image showing you that she doesn't have that. And I was almost surprised that on this radiograph with so much PE that we don't have findings of elevated CVP in terms of distension of the SVC and the azigote vein, even though there is a substantial amount of pulmonary embolism present. So that is a little perplexing too in someone that is syncopal.
So Howard, it's too bad we only had the AP chest radiograph because the lateral view helps in distinguishing lymphadenopathy from enlarged pulmonary arteries. The main pulmonary artery is also convex in this person. So
very slightly, but within that range that, yeah. But yeah, I really wish I'd had that history. Might have triggered something in my brain. I hope. Okay, let me show you. Oh, this one is actually quite interesting. So this is a patient with a radiograph that looks like this. Two big findings are an abnormal opacity in the region of the right hilum, in the parahilar region, but also a peripheral lung opacity in the upper lobe. Now, there used to be a sign that connected these two. I can't remember if it was called something like the dumbbell sign or something that alluded to the fact that there may be a causal association between this and this when this turns out to be a tumor, which this one is. So let me show you the images that go along with that. So first for the lung, this peripheral opacity is very consistent with an area of pulmonary hemorrhage and very consistent with that consequence of ischemia, kind of opacity that we're used to seeing in a patient with acute pulmonary embolism, where the peripheral opacity is that of pulmonary hemorrhage and perhaps an unknown amount of internal infarction. And here is the central mass. So can we associate this central tumor with the peripheral finding? And the answer is easier to perceive on the coronal, because the answer in this case is yes, it's not two separate things. So look at the degree of tumor encasement of the vessels. And I'm going to make this a little bit bigger. And you can see how narrowed and encased that vessel is. But actually, when you follow vessels towards this thing and look for contrast in them, you really don't see it. So there is slow flow in there. Let's see what else I can show you there. But particularly in an image like this, I think there is slow flow in the vessel distal to here. I don't actually see an embolus in there. I don't know what's quite in there, but certainly this should be a brighter vessel like this one should be. So clearly, I think that we have slow flow and definitely ischemia causally associated with what we see here in this particular patient. So we can indeed connect the two up. Do you guys agree?
Yeah,
Yeah.
It's a nice image there.
Yeah, right there. That should be brighter.
Has anybody seen this before? This is a new one for me, but I really love it.
Yeah, I think, I'm not positive, but I think I remember someone describing that or writing an article about the combination of central lung tumors and peripheral lung infarction and giving it a term, something like I described, a dumbbell lesion or a barbell lesion or something like that, to describe the two things that one sees.
I've seen it in fibrosing mediastinitis. So yeah, I would think tumor would do it even more often just because it grows faster.
Yeah.
And if you get like tumor invading the vein, then you have a tumor thrombus that could effectively cause an infarct like a PE. That's really nice.
Yeah.
I like
Yeah, that's an inspector case, isn't it?
Mm-hmm.
Okay, I'll stop there, Jeff.
Right, great. I'm gonna let Travis go. He's gonna try to do it off a hotspot.
See if this works from my 5G hotspot. I'll try to minimize my scrolling. So you guys should see a non-con CT. This is an interesting case. And I'll just leave it with this image or this series of images right here. That there's a peculiar high density metal thing that looks like it's just sitting in the middle of the pulmonary artery. And the history that this guy had was that he had undergone a previous lower extremity thrombolysis at an outside hospital for a deep venous thrombus. And they reported that the catheter tip had flicked off. And so they were doing the study to look for it. And this was originally seen. And then scrolling through later, somebody also saw that there's this here. And I guess the report was that it was just like a tiny little tip. So they thought that one of these metallic fragments was the tip, but couldn't, decide why there were two and why one seemed to just be floating in the middle of the pulmonary artery. And then this patient was referred to one of our interventional radiologists who does a lot of thrombolysis work. And so he thought maybe it was actually a segment of catheter that had been embolized. And so he got a repeat CT with contrast. And now you can see this thing is still in the same place. And this is weeks later. So it's still in the lumen here. And then the other one is still lodged in the same area. The patient incidentally has additional pulmonary emboli now. And then he asked me to look at this and was there anything connecting them? And I think that you can kind of see here when you really window it, that it does look like there's a little tiny catheter fragment or a catheter tubing. And this is like a little micro catheter. And when I did reconstructions doing multiplanar, sure enough, it looks like this does extend. Now there's a little bit of, I don't know if it's a streak or just, it's not the greatest study, but I think this all goes out to that. So I think this is probably just a length of several centimeters of the actual thrombolysis catheter that fractured and then embolized. So we're still waiting to see if they're going to retrieve this with a snare, but I think there's something for him to grab onto. What do you guys think?
Yeah, it's a hard one, but certainly there is something seems linear.
Yeah, I just thought it was really interesting on the non-con because they were not expecting two separate metallic things, one of which seemed to be floating or suspended in the middle of the pulmonary artery.
So Travis, does that catheter have some radiopaque markers in it? I mean,
yeah,
we don't see a fluoro image of the itself.
Yeah, I would assume it's like an ECOS catheter or something like this, and this was all done at an outside hospital. And maybe they did document, because I've been involved in a couple of these cases before where they go to lengths to document like what length seems to be retained. And you would think that they would know the length of the catheter and see that several centimeters were missing. And that's information from the outside that I don't have. But I do think that this is probably the catheter going into that thrombus and then down into the right lower lobe. And then I'll just show this one really quick. This is a nice companion to how or to the case that Jeff showed earlier. And I'm showing these out of sequence. This is the more recent radiograph, and I'll show you the CT after this. But this is a patient that recently came in. He's a vet who is apparently a priest, and he does a lot of he does a lot of work in lower income areas, I think, and that kind of comes into play. But you see there's this opacity in the medial right upper lobe, and I don't know how well these actually project, but you can see that there are lots and lots of little micronodules, and they seem to be a little bit more in the upper lobes, asymmetric, right greater than left. So he didn't actually have a radiograph when he came in. He had an abdomen and pelvis CT for abdominal pain, and they noticed some nodules and then got a chest CT for further evaluation. So we can see these are random micronodules or miliary nodules, if you will, and then there's an area of consolidation in the posterior segment of the right upper lobe. Now, when I reviewed this, the pulmonologist asked me what I thought, and of course, first jumped to tuberculosis or miliary infection. He did not have a history of cancer. Pulmonologist said that he had 3 negative AFB sputa, and I wasn't necessarily completely dissuaded from that. Another finding, as I scroll down, you'll see is that the nodules do tend to be more in the upper lungs, and this is something I've mentioned before, and as far as I know, it's still anecdotal, and I've never been able to prove it, but in the cases of TB that we've seen, oftentimes when it's miliary, that does seem to affect the upper lungs more. And my theory and Brett's theory is that this has to do with the difference in oxygen. And but anyway, this patient also had some bulky nodes. So they did a bronchial lavage and did a transbronchial FNA of this lymph node. The lymph node came back positive for AFB on the smear and eventually grew or isolated TB with PCR. And what's interesting too is that they did a sputum after the bronchoscopy, after his 3 negative pre-bronchoscopy sputa, and that the one afterwards was positive, 1 out of 2 for AFB. So I was talking to the pulmonologist, and he said this is a known, phenomena. He had never observed this before. It's been reported a few times, where pre-bronch sputa will be negative, and then the post-bronch will be positive.
Oh.
I think, yeah. This article though kind of raises some more questions though, because if this is, they don't talk about in this article whether these are patients that they suspect airways centered reactivation tuberculosis. There's no imaging in this at all. Or in this case, I think there's probably the infection was that consolidation in the right upper lobe, like maybe an airways infection, and then it disseminated in a miliary random distribution throughout the rest of the lungs. But I'm not surprised when they say that they're negative sputa if he's not having a productive cough when you have miliary nodules. And so I'm curious, everyone else's thoughts on the whole outcome of this case, and if you agree with the reasoning.
So, Travis, I was going to add, you pointed out that consolidation up there. There are some tree and bud nodules or bronchial centric.
Around here.
I wonder if this is, like you suggested, this is primary TB in the air in the lung that then disseminated through the bloodstream. And typically when but there's not a ton of stuff in the airway, so maybe that's why the sputa were normal. And maybe by the time they did the bronchoscopy, it had spread more, or they kicked it around. I mean, they usually.
Yeah, exactly. He said it was a bloody, like they did some transbronchial biopsies and were pretty aggressive here. So, for lack of a better term, they just kind of stirred things up, perhaps.
Right, and if it's primarily away from the airways, and you do some transbronchs, you now have organisms spilling into the airways.
Right.
And I wonder if that upper zone predominance is more of an artifact of that this is not disseminated to the lungs from somewhere else, but rather starting in the lungs and disseminating on top of that. You just have more, because I've seen the opposite. I've seen it in renal patients, and they tend to have fairly diffuse distribution. I mean, when there are this many nodules, but without really the basal sparing.
I don't know. I've seen 3 or 4 cases in the last few years of disseminated TB with a clear upper lung predominance of the nodules in a random distribution, which obviously flies in the face of like this being metastatic disease,
right?
From a hematogenous source. Yeah, I don't know. I just I said it's still anecdotal observation at this point in my book, but it's curious.
It is curious. Wow.
Okay, Jeff, I will stop there.
All right, that worked great, by the way.
I've got a couple, Jeff, if you want.
Sure.
So I want to start by reviewing a case that I showed a couple of months ago that was a man who developed a mediastinal mass around the descending aorta after he'd had ablation. This is about 4 weeks after catheter ablation for atrial fibrillation. And I'd never seen a hematoma in this distribution before, this periaortic hematoma. He got a stent, aortic stent at that time. I'm not sure whether that was done at the outside hospital or done at our hospital. So I showed this case before. So as part of the work up here, people, thought this was very strange. There's accompanying pleural effusion and all that kind of stuff. So he did get a PET scan, and the PET lit up this lesion. It also lit up some nodes in the neck. And so the neck nodes were biopsied, and they got back a diffuse large B-cell lymphoma. So what I thought was a periaortic hematoma that was organizing and was warm on PET for that reason led to a biopsy that showed that this was really lymphoma. So Occam's razor here, trying to attribute everything to the ablation procedure, was incorrect, and Hickham's dictum, which is the patient can have as many diseases as he damn well pleases, actually prevails in this case. So this periaortic tissue here was not hematoma, it was lymphoma. So I'm sorry to have misrepresented this case when I showed it back, I think, in December. Okay.
Very interesting.
If I recall our discussion, I think we talked about it possibly being lymphoma.
Yeah. So, I mean, a big mass like that, a big soft mass, lymphoma is definitely on the list. So let me show you another mediastinal mass here. This is pretty meaty. It's up in the left upper mediastinum. It maybe has some fat vessels around it, stuff like that. It's lighting up quite a bit with contrast. It's blushing very nicely. It's sort of at the origin of these vessels off the aortic arch. So it's sort of in a vessel crotch and stuff like that. And all of that is very provocative for what the diagnosis turns out to be. So before he had surgery to remove this mass, he did get a dotatate scan, a gallium dotatate scan. I hope I'm pronouncing that correctly. And it lit up this lesion. So this turns out to be, on resection, a paraganglioma, as expected. So a blushing mass here with some fat vessels around it in the mediastinum, and probably originating sort of at the origin of these vessels from the aortic arch. I'm maybe pushing that a little hard. It's not a bad location, periarterial location. So paraganglioma.
Is it possible that, or at least reasonable to think of the possibility of just thyroid tissue that's ectopic in the mediastinum, or is there too many vessels associated with it?
I like that idea. You know, usually thyroid tissue does have a connection, but sometimes it's completely separate from native thyroid. I think I know one potential argument against that is that this lesion seems fairly soft. It's not really bulging contours, and my experience with thyroid lesions, they tend to be very firm tissue and they push on things. So this one isn't pushing particularly, but maybe it's just not big enough to push. So, you know, that would be a possibility for a blushing lesion. And as a matter of fact, I have seen a case about 3 months ago of that very phenomenon, a blushing lesion in the mediastinum that turned out to be ectopic thyroid. So good point.
Okay.
Okay, and then I'd like to show you this man who has CML, who then converted to acute myelogenous leukemia, very aggressive. So he was in a blast crisis, and he has chest wall pain, and he has this destructive lesion here of his manubrium. And this lesion, this is imaging in January, but back in December, this lesion was not as advanced, so it's progressing rather rapidly. And there were some other lesions scattered around the skeleton too. So this is in the setting of myelogenous leukemia, especially if there is a macrocyte component to the leukemia. This is very good for chloroma or what's it now called? Granulocytic.
Or myelogenous, I think myeloid sarcoma now is what they call it.
Myeloid sarcoma. It keeps changing.
I liked chloroma.
I like chloroma too because, you know, think green. So this is probably a chloroma. So the question is about, because he's symptomatic, whether to give this a little palliative localized radiotherapy to try to sterilize this mass, or just see if they can get the leukemia under control. But right now the leukemia is winning. So chloroma here with this sternal destruction. And let's just check it out here on SAG. You can see the extent of this mass here. Okay, so yet another, you know, thoracic chloroma. Okay, guys, so I hope I set the record straight on that non-periaortic hematoma. So I apologize for getting everybody excited about an incorrect diagnosis.
David, I have a question for you, because you've seen, I mean, the bone marrow transplant started out in Seattle a long time ago. Have you seen I feel like we don't see as many chloromas or myeloid sarcomas anymore. Do you think that's true? Or I presume, I mean, they have much better treatment options now.
Yeah, they're so sporadic and so uncommon that it's hard with infrequent events to determine if there's much of a trend. So I'm not aware of a trend, but as you say, if there is such a trend, it's probably that there's more effective therapy.
Because I feel like we're seeing more AML now because of a lot of it's post-treatment, like post-chemo from doxorubicin, as it seems to be a fair number of the AML patients.
Right.
So I was just curious, but yet we don't see as many. I maybe see one every couple of years that I'm aware of.
Right.
Okay.
Well, that's about the same frequency that I think I see, one or maybe 1 a year at most.
Okay.
So it's not common. And usually the diagnosis is not made on a biopsy. It's made on response to therapy. So if they can knock the leukemia down elsewhere in the body, it also tends to melt where it's formed these masses.
Right. Okay.
Okay.
Thank you.
Thank you.
All right. Peter, do you have any cases?
Yeah, I got some, Jeff.
All right.
I'm just gonna go back to the one I showed from a few weeks ago as a companion to your case.
I'm trying to remember that, but that's right.
But yeah, I guess it doesn't look exactly. I mean, it looks like it's posterior to the pericardium here, right? But I think we ended up calling this a posterior mediastinal lipoma, which is also really rare. But it seems like it's continuous with the esophagus too.
Right, and you can also see that it looks like the capsule or the pericardium is between it and the.
Yeah. Right. Yeah. So it doesn't quite look like yours, right?
Right. Mine had the pericardium on this side.
Yeah. Cool. Okay. I'll go to the next two are pulmonary hypertension cases, and I was hoping to get your guys' opinions on them. This one, let's start off with this one. This is a, let's see, there's two images. I'll show the October one. This is a 45-year-old lady with scleroderma, and the most notable thing here is the right heart is, the chambers are enlarged. There's clearly, you can see RV hypertrophy here. And of course the PA is very large. She has a PA catheter. So looks like pulmonary hypertension with RV pressure overload. And the lungs are also abnormal. There's this diffuse, these diffuse ground glass opacities. So with scleroderma, I know there's a definite association with PVOD and PCH. So that's one thing I thought about. And I'll show the follow-up also. So this is actually the one I read from a few days ago, and the one that I just showed was the prior. But the ground glass is actually increased. She's developed some volume overload overall with bilateral effusions, and of course, again, the right heart abnormality and the large PAs. So we talked to the pulmonologist about this one. They also entertained the idea of PCH and PVOD, but they said that they started her on Flolan and they gave her a challenge, and they didn't note any pulmonary edema, acute edema. So they kind of discounted that as a diagnosis. And I think they're just treating this as they're keeping her on Flolan, treating her as pulmonary arterial hypertension. But what do you guys think?
I think I would dictate this very strongly as consistent with PCH
Yeah.
and PVOD with signs of interstitial lung edema, and then the development of pleural fluid. Now,
Yeah.
I had a recent case in which I had a similar situation where the pulmonary hypertension team was rather dismissive of my description of findings on a CT from the outside,
Yeah.
saying, well, we treated this patient with a vasodilator and he's doing okay. So I spent some time looking into that, and at a later time, I'll show you some articles that I found. But the usual teaching that patients will do badly when they're treated with vasodilators turns out not to be the case. Like anything else, it's not the golden rule. And indeed, one can find articles, and one I'll share with at a later time, where the folks treated patients with vasodilators, even though they had this entity, and they actually did okay. Not only did they not get lung edema or have that adverse reaction, but their pulmonary pressures actually improved. So that distinction that used to be made fairly rigidly, I think, is not the case. And again, I've had the same experience where they were dismissive of my observations, and it kind of surprised me a bit.
Well, I have a question about this case, though, Peter. How do they have a long-standing history of pulmonary hypertension related to scleroderma? Because I think this could all just be explained by long-standing pulmonary arterial hypertension. I think the context of new diagnosis of pulmonary hypertension with these findings, then you say, yeah, it's pulmonary capillary hemangiomatosis or PVOD.
Yeah, I don't have the best answer to that. These are the only 2 scans that we have in the system, and I should have spent more time digging back in the chart, but I don't think they had. I think we only have notes back to October, as far as I know. Yeah, if you came in from somewhere else around October.
Because I think that can make a big difference.
Yeah. Yeah. Now, have you seen, so with what you're saying with the PAH, I'm used to seeing just more small, finer nodules, more like central or periaortic arteriolar nodules. Have you seen this much confluent ground glass?
Well, some of that could be edema in the acute setting, right?
Right.
Yeah. There's no, but at the same, I don't see the septal thickening at all, you know?
Yeah, I think that's a very good question. I've not seen this much ground glass from just the proliferation around small arteries, the plexiform arteriopathy. So when it's confluent like this, I would really go with the PCH. And I agree that very septal lines here to really pinpoint the edema.
Yeah.
The other thing is that I think anytime if you've got really bad right heart failure, you can get pleural effusion. So I don't think that points to a specific diagnosis for the pulmonary hypertension.
Right. Yeah. And then she has been accumulating more and more fluids since October, even on the Flolan, which might be just from the backup from the right heart failure.
Does she have ascites too? Because that would point towards some hepatic dysfunction. Was there ascites down at the bottom?
Yeah, just trace.
A little bit, yeah.
I should go back and check if they have a left heart pressure, if that's normal. But I'm assuming it's normal because I don't see any venous accumulation here, and there's no septal thickening. But
well, it doesn't have to be from left heart failure either, as David's saying. If she has liver disease, if she is hypoalbuminemic, there could be other explanations. I just think taking a Bayesian approach that patients with scleroderma have a very high incidence of just pulmonary arterial hypertension. Yes, they have a higher incidence of PVOD and PCH as well. But if this is long-standing, it's probably all just related to run-of-the-mill Group 1 PAH.
Yeah.
That's why I think the acuity of symptoms and her history are important here.
Yeah, that's a good point. Yeah, I'll go back and see if I can dig more into how far back it goes.
Another possibility on glass is that she's got some pulmonary hemosiderosis from depositing iron in her lungs from, just from low-grade bleeding and things like that. So there are to get some ground glass in those lungs.
Yeah, yeah. And she's not going to get a biopsy, unfortunately, because of the too high risk because of the pulmonary hypertension. So
maybe hard to know. I do have that article up, so at the end I can have Jeff give me the screen so I can just show it to you.
Yeah, yeah. I had one article that I was looking up with the challenges, but it's probably not. This one just for patients with scleroderma and PCH. And then as far as the differentiation between PCH and PVOD, do you guys consider this a spectrum? Because I know classically in some of the articles they talk about the septal thickening and stuff like that with PVOD, which I don't really see here.
Yeah, I think
concurrently, so you can have findings of both. You can have central lobular nodules in the ground glass of PCH and then the interstitial edema of PVOD at the same time, same patient.
right. And also I think the pathologists, at least the ones I've worked with recently, considered a spectrum of the same process. And
yeah, that's what I've been.
Howard, did you need the screen for a second?
Yeah, I can show you. Just quickly, I'll just display the article and you can just take note of it and you can always find it again. But just to indicate that things get fairly complicated. So you see this right there? There's one that I found, and here you can see a report in patients with PVOD treated with some of the newer medications, including vasodilators. So time for the rethink, question mark. So yeah.
Interesting. Okay.
Yeah.
All right. Back to you, Peter.
Yeah. Okay. Show my other. Maybe this one's more straightforward. We'll see. My other pulmonary hypertension case. This one is a very large pulmonary artery. Impressive on chest X-ray, but I didn't include the chest X-ray. This is a 70-year-old lady, and she has some other conditions. She has breast cancer, recently started on chemotherapy, and she has coronary artery disease and stents, I think. Yeah. AFib with a Watchman device, not on anticoagulation. So clearly pulmonary hypertension. She has atherosclerotic calcifications here in her pulmonary artery. And there's this thing here, this filling defect. I think down here there was a little something that looked like a web, but one of the residents picked up something down in the left lower lobe that looked like a web. But anyway, they were called PEs, but I thought this might be just in it. I thought this might be in situ thrombus in the pulmonary artery in somebody with PAH, rather than there are no other findings of CTUF here that I was impressed by. There's no mosaicism or distal pruning or bronchial arteries. So I didn't really like it for CTUF, and I thought this might just be a focal in situ thrombus in somebody with atherosclerotic plaque.
It's odd, it's just one area.
Yeah. What do you guys think?
Yeah, I agree. It probably is in situ, given that it's just right there and kind of a big blob for a chronic clot.
Yeah, it's very much as like a broad border with the wall there. But she's so
interesting.
And then one last one. I don't remember the age of this patient, but she has dermatomyositis, and she has kind of a classic ILD pattern that we see with dermatomyositis, with fibrosing NSIP pattern at the lung bases. It is a little bit asymmetric here. which I'll come back to on the left side. So we'll look at a follow-up and we'll come back to that. So this one was from 2018, and I'll add the 2019 scan. Yeah, 2019 on the right side. And so here, there's now a nodule there on this side. And so this was biopsied, and as you would expect, this came back adenocarcinoma. There's also a PET, which shows that this was FDG avid, and here's the biopsy result. But it was kind of just, it's kind of an interesting case how you see the
It's
asymmetric.
interesting. The path showed it was at 70% lipidic predominant, but can you scroll through the mass again? It looked pretty solid.
Yes, on the second CT, yeah, there's a solid nodule with invasive adeno.
Makes you kind of wonder if with all the fibrosis and the smaller alveoli, you can get a denser appearance with a lipidic pattern, because we typically think of those as the part solid ones, but or the ground glass component's hiding because it's blending in with the surrounding fibrosis.
Yeah, that's exactly what they were.
What did they say the final tumor size was? They usually report that.
Maybe I missed that part of I didn't.
That'd be interesting to see. Let's see what they say. They called it a T2A, so it's not so it's not huge.
Yeah, and then here they were kind of going back and forth on whether the ground glass is underlying fibrosis or tumor.
Yeah, oh, that's interesting.
But it's like one of those things where retrospectively you look back and but
no way can we even think
no, yeah, you're not going to call that.
No.
No, never.
Yeah.
Asymmetric ground glass, but no.
Yeah. Yeah, that's all I got.
Great. That's a great case. All right, everyone. Well, thank you very much, and we'll talk to you next week.
Yeah, great.
Thank you.
Have a good weekend.
Bye-bye.
Bye, everyone.